genetic testing. What are commonly available genetic testing now at present, commonly used, and how to pick those genetic testing for set of patients. How do we select patients? How do we select their testing? And how do we interpret it? These are some of the things I will try to cover within 10 minutes time. So as everyone knew that there is an extensive phenotypic heterogeneity with respect to certain diseases. All these diseases come under one group called ABCA4 gene defect. So there is an extensive phenotypic variable. It's the same gene giving rise to different phenotypes. And second, in LCA, similarly, there are a lot of genes that can call CA. So there is genetic heterogeneity as well. So phenotypic and genetic heterogeneity are present. So phenotyping and looking for genes is not that easy. In that, but with available tools, we'll be able to 90% will be able to identify genes in many of these conditions. And what is the impact of finding out the gene defect in those patients? How does that help in the management of the disease? It confirms the genetic nature of the disease first, which is very important, and it may predict the progression and outcome, especially for ABCA4. It helps in understanding the progression of the disease. It can prevent the transmission of the disease to the subsequent generations if prenatal diagnosis is done after detecting the gene defect in the patient. It can also modify our management strategy, as Dr. Vikas clearly pointed out, like withholding vitamin A for ABCA4 and putting up if CACNA2D4 gene defect can do very well with Dorsox. All our osmolytic agents, it works very well with those patients. It reduces the progression. So, and with lutein zeaxanthin supplements and avoidance of light in trauma ABCA4 defects really help the patient in preventing the progression of the condition. And we can also prepare the patient for the therapy in future in the form of a gene replacement therapy or a photoreceptor transplantation. Whatever be the case, there is a remarkable difference in the prognosis or the treatment success in those patients based on the gene defects. So how do we go about? There are certain steps that are involved before and after molecular testing. First is pedigree charting. Whenever a patient walks to my clinic, first thing what we do is that take a pedigree of the patient, determine the inheritance. That gives me a clue what kind of patient I'm going to see. And then visual evaluation again is important, looking for whether it's going to be a cone deterioration more or a rod deterioration. That will put my mind into think what kind of gene defects probably would address that problem. And then diffraction. High myopes, most probably I always say anything above -5, I always look for ciliary group of gene defects. And nearly 85-90% I come out with Usher2A. I come out with a lot of other genes that are ciliary in origin. And diffraction, as we all know, plus hypermetropes, minus myopes, mostly they progress much better. Whereas hypermetropes in many conditions, like as I normally come across achromatopsia or rod monochromatism, where patients don't progress that much. And history is very important. What is the duration of the disease is very important. And second, the progression of the condition, we should ask the patient how progressive the condition is from the time it was noticed. And three, whether he was born out of consanguinity and any other systemic illness that is present, as Dr. Karthikeyan clearly mentioned. And finally, looking at the affection status in the other members in the family is very important to understand the genes that might be responsible for the condition. And then ophthalmic evaluation, taking all these things into consideration, both anterior and posterior segments should be evaluated, and investigations to support our thought process, and then diagnosis. Diagnosis, I normally have a different way of putting my diagnosis. I say it is autosomal dominant or autosomal recessive first in my diagnosis part, followed by either a primary epitheliopathy or a primary photoreceptor degeneration, followed by a secondary condition, could be a secondary photoreceptor or a secondary epitheliopathy with probable gene defect that might be responsible for the patient condition. I don't put, in bracket I put Stargardt's, in bracket I put fundus flavi maculatus, that's different, but I always put that way so that it gives me an idea. I'm more thinking of the genes that are probable cause for the disease. And then treatment, as I told you, based on our findings, we can put the patient on treatment, safe treatment that either helps to some extent halt the therapy, halt the progression of the condition. And then we offer the pre-test counseling before going to the molecular test. What do we do in pre-test counseling? We analyze the family history for potential inherited diseases, assessment of risk of occurrence of genetic condition in the family, discussion of the nature of the disease and contribution of the heredity, discussion of options that are available to reduce the disease, including the testing. So all these things are discussed before a patient is subjected to molecular testing, and an informed consent should be obtained. I get two informed consent, one for the testing, two for use for research purpose. It will be two different informed consent. The patient might deny for research, they can go for testing alone. So these are very important before you go for a genetic testing. And then followed by a post-test counseling. This help the patient to understand the meaning of the testing and help the patient and help the doctor himself to manage the patient better. And I document everything in my thing, both investigations as well as the genetic reports, and then follow up. So, what are the different types of genetic testing that are available for our set of patients? It can be in the form of a karyotyping. It's a conventional karyotyping, like the chromosomal analysis that we do. It's able to identify all numerical and structural chromosomal abnormalities. Turnaround time is around 2 to 3 weeks. It takes 2 to 3 weeks for us to get a report. And then there is some degree of subjective error, but in good labs, no, it is not so. It costs anywhere between 1,500 to 4,500 rupees depending upon the institution. And on the same side, now microarray-based karyotypings are getting popular. It is a DNA-based karyotyping. It's able to identify all numerical and structural chromosomal defects. It takes 2 days to 2 weeks to get a report, and there is no subjective error here. And the cost is a bit higher, 8,000 to 10,000 rupees per patient. On the molecular side, we have restriction fragment length polymorphism, which has been there. I always use sometimes this technique to screen the controls. I'll come across why you need to screen controls over a period of time. Able to identify single mutations in a gene. You can't keep screening all the mutations, but designed in a way that it identifies single mutations in a gene. It will not be able to screen entire gene. Good for recurrent known mutations. It's less cost and it takes very less time to complete. So these are some of the advantages and disadvantages of RFLP. And then the gold standard, the Sanger nucleotide sequencing, is able to identify all the mutations in a gene. It's a gold standard and very precise. Screening one gene at a time, more cost and takes longer period to report. It depends upon the size of the gene. When you want to select for a pure Sanger's, I would prefer any gene less than 10 exons. Like retinal diseases which have 5 exons, choroideremia, CHM gene which is very small, and OAT, ornithine aminotransferase for gyrate atrophy is very small. You can screen very easily and give a report in a week time. Whereas above that, I do a different technique in screening. Yeah. Then the next gen sequencing technology, able to identify all the mutation in the gene, screen 50 to 100 genes at a time, and relatively less cost and time than Sanger's. It needs clinical and molecular biology, but it needs good phenotypic documentation and molecular biology knowledge to clearly pick the gene, because you'll get 5 to 6 mutations in clear-cut mutations in genes, which will be able to decipher only if you have a good phenotypic knowledge. So this is a Sanger sequencing technology. I'm not going in depth into this. This is RFLP again. As I told you, I'll use mainly for control screening because it is cost-effective and less time-consuming. I'll discuss few cases here. You can see that the patient has a sporadic case where the history goes with ABCA4. There is a white flakes in the perifoveal region. I suspected Stargardt's. I screened ABCA4 positive. You can either use Sanger sequencing, but the gene is very large. But since I have a project in that, I screen directly and get a mutation in that. This is a second patient which is an autosomal dominant pedigree. And the fundus looks more of an autosomal dominant disease. So I screen all the autosomal dominant genes because I was not very clear which gene it could be. In such cases, I screen all the autosomal dominant using next-gen sequencing technology, and I got with a PRPF31 with a mutation. And it is very important. Once you identify a mutation in next-gen, it has to be confirmed by Sanger's, and it has to be run on family. A family segregation should be done to complete to confirm the disease again. And if it is a novel mutation, it has to be run on 50 or 100 controls to show that the controls do not carry that variation. This is very important before you give a report to a patient. And then this is a very vague phenotype. Pedigree-wise, it is autosomal recessive, but when we sequenced and when we segregated, it was an autosomal dominant prominent gene defect, which has transmitted. The father was not affected. When I went back and looked at the ERG definitely showed decrease in amplitude. So, taking a peripheral blood, we'll do a cell culture, karyotyping, DNA isolation, we do a PCR, and then we can do from PCR, RFLP and Sanger sequencing. Microarray karyotyping can be done and next-gen sequencing. So, coordination of test report after post-test, composition of summary letter, The summary letter will have the diagnosis, will have the genetic variation and the validation of the testing. This is how the workflow is. Thank you.